Yeah,
Recording in progress.
Good morning, good afternoon, and good evening, esteemed professors, speakers, and all participants from across the world. I welcome you from IPA for the webinar on new therapies in pediatric oncology by the IPA program area on pediatric oncology. Before beginning the webinar, we will go through the instructions. If you have questions for the speaker, kindly put them in the Q&A feature. To receive the certificate of attendance, participants must attend the entire duration of the webinar and complete the feedback form, which will appear after completion of the webinar on the screen. Please note that the Zoom closed captions are generated by AI, and there may be instances where the translations are incorrect or misleading. We appreciate your understanding in that. Now, it's my pleasure to welcome the moderator for today's webinar, Dr. Ekanem Ekure. Dr. Ekanem is a cardiologist at Lagos University Teaching Hospital with over 20 years of experience. A fellow of the West African College of Physicians, she holds an MD from the National Postgraduate Medical College of Nigeria, and she is the president of the past president of the Pediatric Association of Nigeria, and serves on Key International. Over to you, Dr. Ekanem.
Thank you very much. I'm really delighted to be here and to welcome us to this webinar. I have the rare privilege of having in the room the president of the Pediatric Association of Nigeria, a very compassionate neonatologist, and I say that with firsthand experience because I've seen him demonstrate that passion. We thank you so much for making out time to join us, despite a lot that's going on the IPA side and even back home in the country. Thank you very much, sir. Handling this webinar subsequently will be another colleague of ours who I will just mention. Dr. Sima Ferman will handle the technical session of the webinar. But at this point, I will hand over to the IPA president to give his opening remark. Professor Joseph Haddad, over to you.
Thank you very much. It's really a great honor and pleasure to be always with this this program area on oncology, which is one of the most active in IPA. I wish to congratulate you with Nita regarding this extensive work that you are doing. New therapies are very important, and I hope that those new therapies will be available all over the globe, and particularly in low and mid-income countries where we're encountering a lot of issues. I hope that you will bring some news that are helpful for those kids in this part of this world. I now, without further delay, I really appreciate all of your interventions and leave the floor to the coordinator or moderator of this group, of this webinar. Thanks a lot.
Thank you very much, sir.
So now we welcome Dr. Sima Ferman. Dr. Sima Ferman is an MD, is a pediatric oncologist and head of the Pediatric Oncology Department at the Brazilian National Cancer Institute. She leads clinical care, research, education, and innovation initiatives in pediatric cancer. Her clinical and research interests include pediatric solid tumors, neuro-oncology sarcomas, precision medicine, and the development of child and family-centered models of care. Dr. Ferman has also contributed to international educational initiatives and collaborations aimed at strengthening pediatric cancer care in LMICs. Over to you, Dr. Sim.
Thank you very much for the introduction. Good morning, good afternoon, and good evening to colleagues joining us from different parts of the world. On behalf of the International Pediatric Association, it's my great honor to welcome you to this webinar dedicated to one of the most exciting and transformative areas in pediatric oncology, the development of new therapies for childhood cancer. Over the past decades, pediatric oncology has become one of the greatest success stories in medicine. Advances in diagnosis, supportive care, and treatment have dramatically improved survival rates for many children with cancer. Nevertheless, important challenges remain. Progress has not been uniform across all pediatric malignancies, and outcomes continue to be poor for children with relapsed, refractory, and high-risk disease. Cancer remains one of the leading causes of disease-related mortality among children and adolescents worldwide. Furthermore, many survivors experience significant long-term treatment-related sequelae that can adversely affect their quality of life. This persistent challenge continue to drive innovation in our field. Today, we are witnessing a profound transformation in the way we treat childhood cancer. Precision medicine, targeted therapies, immunotherapy, and cellular therapies are opening new possibilities for our patients. Increasingly, treatments are being designed to target specific molecular pathways, genetic alterations, and immune mechanisms, with the goal of improving outcomes and reducing toxicities. During this webinar, we will explore some of the most important advances in the field, including targeted therapies and immunotherapy in pediatric cancer, the revolutionary impact of CAR T-cell therapy in leukemia, and the growing opportunities and challenges of CAR T-cell approaches in solid tumors. These advances are redefining what is possible in pediatric oncology. Our task now is to ensure that the benefits of innovation extend beyond scientific discovery and translate into better care and better outcomes for children everywhere, regardless of where they live. Although many of these therapies are developed and delivered in highly specialized centers, their success depends on the entire pediatric healthcare community. Pediatricians play a special role in the early recognition, timely referral, support throughout treatment, management of long-term effects, and advocacy for equitable access to care. I would like to sincerely thank our distinguished speakers, our moderator, the organizers, partner institutions, and all participants for joining us today and for their commitment to improving the lives of children with cancer around the world. Most importantly, we dedicate this meeting to our patients and their families. They inspire us every day to start for better treatments, better outcomes, and better care. Thank you very much for being here. I wish an excellent webinar. And now it's my pleasure to introduce our first speaker, Dr. Nita Radhakrishnan, who will speak about immunotherapy and targeted therapy in pediatric oncology. Dr. Nita Radhakrishnan is additional professor and head of the Department of Pediatric Hematology Oncology at the Postgraduate Institute of Child Health, Noida. She is coordinator, Pediatric Oncology Program Area Working Group, International Pediatric Association, contributing to global frameworks designed to optimize early diagnosis, referral systems, and standards of care for childhood malignancies. Her clinical academic work encompasses leukemia therapy, infection management in immunocompromised children, and health system strengthening with active involvement in national and international collaborations that advance pediatric oncology care in India. So now it's over to you, Dr. Nida.
Thank you. Thank you, Dr. Furman, for that kind introduction to the topic, as well as discussing about what are the possibilities that lay ahead for today's webinar and for the children who suffer from cancer. I hope my slides are visible. So my section of today's topic is immunotherapy and targeted therapy. Before I get to that, I would like to briefly introduce the concept of what are all the changes that have happened in the last few decades in children with cancer, or advances in pediatric oncology as such. So like you mentioned, there are a lot of changes, that there is a revolution that's actually happening right now. And there are treatment is becoming much better, much milder, and with better outcomes as well as lesser toxicity. And so how did we reach there? It is safer, smarter, and more precise, because we have advances in diagnostics, better risk stratification, targeted therapies, and immunotherapy. This is the section that I'll be dealing with. After this, we'll be hearing from the next two speakers on chimeric antigen T-cell therapy. Then there have been advances in radiation oncology, avoidance of toxicity in many pediatric cancers. So as children, as cure rates improve for children with cancer, the idea is to cure more with lesser toxicity. So avoidance of toxicity over the years, reduction in radiotherapy doses, and the betterment of radiotherapy, how to administer radiotherapy, improvement in chemotherapy in terms of what to give, and maybe intensive, just increasing intensity is not the answer anymore, and so on. So this is what we have learned. And finally, late effects mitigation, and the fact that you think about a patient as a whole, get the patient reintegrated back into the community, let the child go back into the community and have a long-term good quality of life. This is what we are aiming at. So this is a slide on acute lymphoblastic leukemia outcome from St. Jude Children's Hospital through their St. Jude total therapy studies. And this is one of the very famous images which are there which is there in the pediatric oncology field, which shows you how treatment, the survival has improved over a period of, say, around 40 years, how it has improved from less than 10 years outcome, less than 10% outcome at 10 years from diagnosis to now above 90%. So this is the advancement that we are seeing, which has happened due to a lot of, it's not necessarily new drugs that have actually paved the way to this. It's better understanding of the disease biology. It's understanding how treatment response is there, and identifying children who do not respond early enough so that you intensify those children, and whereas avoidance of intensification for the rest of the children. So this kind of intensification for the high risk, reduce infrequent for the low risk, is something which we are doing in almost all malignancies, and better therapy options as well, as we see. So almost all malignancies that we treat have an element of risk stratification, where you look at different combinations of markers for risk stratifications. In case of leukemias, it would be genetics plus a response, which is response assessment through residual disease. So measurable residual disease is assessed at the end of first or second month of treatment. In lymphomas, it would be the initial staging followed by the response assessment. So it's always how the child presents to you, how did the child respond at the end of like first 1 or 2 cycles of treatment. And similarly for solid tumors, staging as well as response, and how good was the response to initial neoadjuvant chemotherapy is very important in solid tumors as well. So I'll come to the topic per se, which is targeted treatment. So in targeted treatment, so there is immunotherapy and targeted treatment. I thought I'll deal with targeted therapy first, because that happened earlier when compared to immunotherapy. So whenever we administer chemotherapy to a patient, so the chemotherapy generally targets all cells which are proliferating rapidly at a very high speed. So it's essentially targeting cancer cells, but it would also target cells which are growing rapidly. So that is why our hair falls out. Patients have a nail stop growing. There are oral ulcers. There is mucositis in the gut because your endothelial cells, that is the epithelium in the mucous membranes, actually have a rapid turnover, and these also stop working at that point of time when chemotherapy is administered. So these are all things that are contributing to the toxicity in these patients. So what if we could target only the cancer cell and not target any other cell which is rapidly proliferating? So this is targeted therapy, and these are drugs which are designed to inhibit specific molecular drivers of cancer growth. And for this, we need to know what is the mutation for each cell. So for example, in promyelocytic leukemia, it will be different mutation. In a pH positive acute lymphoblastic leukemia, it will be different mutations. But identifying that mutation is very crucial so that you can just target that mutation and only that cancer cell will be killed as a result, no other body. So the child does not lose hair anymore when you're on targeted treatment, and and you don't see the usual toxicity in terms of low counts or having to require transfusions, infections. All of that will not be there if you are on treatment. So this is again an infographic which shows how conventional chemotherapy works, which is less focused, more side effects, and a variable response. Whereas a targeted treatment would bind to that target on that particular cancer cell. It will block the signal, kill the cancer cell, but it will not cause any other side effects. So off-target effects are not there, and there will be a better response because you're targeting that particular cell only, and that too through the specific mutation, there will be higher response rates for these diseases. Because of this, there will be fewer side effects, less treatment interruption, better long-term outcome. And in the era of multi-drug resistant infections, you can imagine what a boon it will be if you can just target the cancer. So it's not something which is very new. It has been there for a long time. It is there both in leukemias as well as solid tumors. We'll come to it in a bit. So one of the important cancers where this has really impacted is acute lymphoblastic leukemia, pH positive or Philadelphia positive acute lymphoblastic leukemia, where traditionally the outcomes have been quite poor. So a subset of acute lymphoblastic leukemia, around 2 to 5% of pediatric ALLs, would have this particular reciprocal translocation between chromosomes 9 and 22, which causes a fusion called BCR-ABL fusion gene. So whenever this fusion occurs, which is occurring inside the cancer cell, it causes a constitutively activated BCR-ABL tyrosine kinase, and that promotes uncontrolled growth of the leukemia cell. So this happens in around 2 to 5% of our ALS. Traditionally, when this used to happen, they see the outcomes used to be very poor. You have very bad prognosis in terms of patients who have around 20% outcome of these cancers. And even in the best scenario possible also, it would be less than 50% outcome of these patients. In those years, when this was just diagnosed and when these children were being followed up with intensive protocols, many would undergo bone marrow transplant also. And despite bone marrow transplant, the outcome used to be very poor. So this is when an agent to target this tyrosine kinase was developed, which is called a tyrosine kinase inhibitor. So now when you have a site, there is an ATP binding site on this fusion protein. When you target this and you give an inhibitor to that area, suddenly this kinase activity gets inhibited. It cannot constitutively activate. It cannot drive leukemia development further. There is no growth signal to that. And this cell undergoes, the leukemia cell undergoes apoptosis and cell death after that. So this has revolutionized the ALL patients. And subsequently, we have incorporated them into our routine chemotherapy. So in addition to the routine chemotherapy that we used to give, we have added TKIs into the treatment, and they can see how the treatment has improved from less than 20% to around 70 to 90%. And now we do not require bone marrow transplant for all patients. Only very few patients who are on TKI plus chemotherapy, but still their response is not great. Only those children go for transplant. The other ones do not require transplant at all.
Similarly, in acute myeloid leukemia, now that there are many agents which can be targeted now in acute myeloid leukemia. So one of them, which is very famous, so where there are multiple inhibitors which can be targeted here, and there are drugs like sorafenib or venetoclax. There are multiple agents now which we add to our routine chemotherapy backbone, which helps us get these children into remission quicker without having to intensify chemotherapy per se. So that is about leukemia. So this has happened across Ph positive ALL, Ph like ALL, even in infant ALL. It's a very important role of having new agents now, which is there. And then subsequently for all solid tumors as well, solid tumors, many solid tumors, like for example, patients with gliomas, patients with neurofibroma, medulloblastoma, neuroblastoma, you name it, many of these agents have diseases have actionable mutations. And if we are able to identify the actionable mutation, you add the agent, it will show improved response. So outcomes have, so for all of these malignancies, outcome response, numbers are different for different malignancies, but definitely outcome has improved. Now the second part, which is immunotherapy. So here in immunotherapy is actually targeting with an immune mechanism. So it is usually an antibody or a monoclonal antibody which is there. So I'll discuss acute lymphoblastic leukemia first. Three targets for immunotherapy in ALL. Initially, there used to be a target of CD20, which is rituximab, and that can be used till now. In some countries, it is being used, but now there are new agents like CD22 inhibition by inotuzumab and CD19 by blinatumomab. So these are targets for the immunotherapy. So this is how. So many of these, that leukemia cell carries these CD markers on the surface. So if you can target that CD marker specifically, it does not cause killing of the other cells, like I mentioned earlier. So it will improve the outcome as well as reduce toxicity. And how this happens, it can happen through, it can cause antibody dependent cytotoxicity. It can carry a cytotoxic agent along with this monoclonal antibody and so on. So there are multiple ways of doing it, but ultimately this is what it does. So rituximab is still there, but it's not so much in vogue. Now, the agent which we are all excited about, which has been there for the last almost a decade, is blinatumomab. Is an agent which is a novel therapeutic class of antibodies, which is a bispecific T-cell engagers. Now you can see this is the drug here, and this drug will target two parts, as in this is the cancer cell on the right side, which has CD19 on its surface. The drug brings CD19 and a normal T cell together, and it engages it together. So now the T cell can directly do cytotoxic, as in these are cytotoxic T cells, and it can actually go and directly kill the leukemia cell. The body's own T cells can go and kill the leukemia cell. And there is nothing better than this. So because you are actually not having to kill other, as in the other cell lines are not pretty much unaffected. So this is a bispecific T-cell engager. So this is pretty much how it works. It causes T-cell activation. It releases cytokines, perforin, granzymes, etc. And it results in apoptosis of the B-cell ALL. So this has been, again, there is no MHC class restriction, because of which there is direct engagement of the T-cell and lysis of the blast. Of course, there would be side effects in terms of when there is T-cell activation, release of cytokines, there would be some amount of side effects because of that. But essentially, if we know how to manage it and if we are able to do it, this is actually a game changer in our in ALL management. So these are the numbers of the trials that have come in over the years, people reporting real world outcome as well. And over the years, this is now had initially in relapse refractory settings and now even in upfront leukemia settings as well. So two major RCTs which showed its response. So it is now even helpful in certain subsets, for example, a Down syndrome associated ALL or infant ALL for that matter. Again, dramatic improvement you can see in infant ALL, where the earlier response disease-free survival used to be around 50%. Now it has gone short up to 80%, and that's how improvement is there. So off-the-shelf product, cost is much better. Cost is better, improving. Some countries, they get humanitarian aid for this product as well, so the patient does not have to pay. Side effects also are manageable, and it helps as a bridge to transplant. when you're using it in relapse refractory setting. Now, even in upfront BALL setting or B acute lymphoblastic leukemia setting also, you can see traditionally chemotherapy would give you around 80-85% cure. Now, with addition of blinatumomab, you can see how the improvement has gone up above 95%. And this is again graphs which you can see. Of course, there are side effects in terms of cytokine release. This is the grading of cytokine release syndrome. And we need to know, you need a good ICU setup. You need to have trained nurses and residents who will be able to manage this patient. And this can be taken up even after transplant also now, so that to prevent relapse of these children. And the pH positive ALL I mentioned earlier, where I said it is now tyrosine kinase inhibitor plus chemotherapy. Now we have some protocols which are using blinatumomab plus tyrosine kinase inhibitor, which is essentially chemotherapy free, an immunotherapy and a targeted therapy together. Similarly, another agent is inotuzumab oxagomycin. Here it is targeting CD22. It's an IgG4 antibody. Here it's slightly different. It is actually carrying a cytotoxic agent along with it. So when it internalizes, it is attaching to the CD22 on the ALL surface. It internalizes it, and then it releases the cytotoxic agent which it is carrying, which is usually calciamycin in this case. And then it releases the calciamycin, it causes cell death. So it is causing only the death of that leukemia cell, and it is not affecting other cells much. So these are the trials which went to got approval for this. The issue with inotuzumab is that there is some amount of hepatotoxicity that has been noted. So we need to handle the drug in a particular way. We need to be very careful of what to give along with it, avoid other hepatotoxic agents. And when you're taking up for transplant, there is a particular complication called SOS or sinusoidal obstruction syndrome that can be there. So you give a gap between inotuzumab and transplant for these patients. So these are the two big agents that have revolutionized change for our ALL patients. What about myeloid leukemia? Myeloid leukemia, again, there is an agent called gemtuzumab oxagomycin, which also, like inotuzumab, it also carries a calciamycin on its surface, and it is again connecting to CD33 on the myeloid leukemia cell. It internalizes and similarly results in killing of the cell, and similar toxicity in terms of hepatic involvement and SOS can be seen, but essentially outcomes of these children improve much better. So I'll stop here by concluding that there has been a steady improvement in cancer care, which is not just because of these two classes of drugs that I showed. It's a lot of other things as well, including comprehensive diagnosis, understanding responses, and a combination of these two drugs, and a lot more advances, which we are going to discuss in the next few talks. Thank you. Over to you, Dr. Seema.
Thank you very much, Dr. Nita. Excellent presentation. So we now will move to the next presentation. We'll have Dr. Anil George, who will speak about CAR T-cell therapy in pediatric ALL. Dr. Anil George is an assistant professor in pediatric hematology oncology stem cell transplant at Baylor College of Medicine, Texas Children's Hospital in Houston, Texas, USA. In his clinical role, Dr. George manages patients with relapsed and refractory leukemia. This management includes evaluating and performing allogeneic stem cell transplant and overseeing immunotherapy-based treatment, including CAR T-cell therapy. Dr. George is also involved in national consortiums and study committees investigating new therapies for patients with acute leukemia. Thank you, Dr. George.
Thank you, Dr. Furman, for the introduction. Sorry, I'm waiting for the slide to come up.
This slide. Please.
Good morning, good afternoon, and good evening. Thank you for the opportunity to speak with you all today about the application of CAR T-cell therapy in pediatric acute lymphoblastic leukemia. It's CAR T-cell therapy is a very exciting therapy. There's a lot of enthusiasm regarding the application of it. We're still learning about the full utility of this treatment plan as far as the timing of when to implement it and also what to do after it. Do you, in certain patient subsets, do you let the patient receive the therapy and as long as they remain in remission, continue monitoring, or do you move to bone marrow transplant? And so it's approved for patients who have multiply relapsed or refractory B-cell leukemia. One of the exciting things about CAR T-cell therapy is that the efficacy can be achieved with just one infusion, and you can see this as soon as a few weeks after infusion. The standard is to perform disease evaluations approximately 1 month post-infusion, and in a majority of cases, we see patients achieve complete remission after just a single infusion. And then early MRD negative response rates of greater than 90% and 1 year relapse-free survival of 60% have been reported for patients who received CAR T-cell therapy, but did not need any further chemotherapy or stem cell transplant treatment. Next slide. So this table highlights the 7 studies that were done to sort of review the implementation of CAR T-cell therapy in relapse refractory ALL. In the patients who were multiply relapsed, they were approved for CAR T-cell therapy if they had at least 2 or higher relapses. And as you can see, the complete response, the complete remission rate was over 80%. Next slide, please. So while there's a lot of excitement and enthusiasm about CAR T-cell therapy, there are some limitations. There are patients who still have early and late treatment-related failures after receiving CAR T-cell therapy, and that's one of the avenues for further investigation to highlight which patients may not be good responders to CAR T-cell therapy, and if there's a way, specifically looking at their cytogenetic profile to identify those patients a priori. The manufacturing and delivery of CAR T-cell therapy is resource intensive, so it's not universally available. And some of the steps involved with implementing CAR T-cell therapy. So prior to the infusion, you have to have an apheresis team that can perform T-cell collection, and then also have a center that can administer lymphodepletion chemotherapy. And while different lymphodepletion regimens have been investigated, the current standard is the combination of fludarabine and cyclophosphamide. CAR T-cell products are high in cost. So the rough estimate in US dollars is about $475,000 compared to a little over $100,000 US dollars for oral chemotherapy. And the CAR T-cell product is very individualized, meaning you're collecting that respective patient's own T cells to infuse back to them after manufacturing. So because the therapy itself is very individualized, it limits the production capacity for how the product can be manufactured. Next slide, please. So we all know that patients who relapse after stem cell transplant have very limited options. And these patients may not be able to undergo or tolerate a second transplant right away due to multiple effects, primarily graft versus host disease, effects from total body radiation, or the effects from myeloablative chemotherapy that patients receive during conditioning. And then transplant-related mortality increases as patients receive subsequent transplants. Next slide, please. So when patients receive CAR T-cell therapy, like any immune modulating therapy, there are toxicities that we have to be aware of, both acutely and long-term. So in the acute treatment phase, what we're looking at in terms of time points is from the time of infusion till about 1 month after infusion. And the primary complication that does arise is cytokine release syndrome, or CRS. That is correlated with the disease burden that the patient has at the time of infusion. So patients with higher disease burden have higher risk of cytokine release syndrome. If that particular side effect were to occur, it typically occurs within the first week after infusion. So patients who receive CAR T-cell therapy need close monitoring and prompt admission for side effects. CRS complications are graded. So grade 1 universally is managed with supportive care. And then immune modulating agents are instituted for grades 2 and higher CRS, primarily with immune modulation with tocilizumab targeting IL-6. As you get further out from the time of infusion, there's other side effects that can come into play, specifically with effects affecting immune reconstitution. Patients can have transient cytopenias and coagulopathy that do resolve. And this is similar to the side effect profile that you do see with blinatumomab. Next slide, please. So one of the questions that we look at when applying CAR T-cell therapy is what to do for a patient who achieves remission. Do you continue on with post-therapy surveillance, or do you look to move forward to a stem cell transplant after? And despite the risk of toxicity that increase as you move forward with subsequent transplants in patients who've have experienced a prior transplant, the chance of a cure with a second transplant is much lower. And the efficacy of CAR T-cell treatment in patients who have already received a transplant is affected by two primary factors. First is the time frame between when the patient received their transplant and when they had their disease relapse. So patients who have had relapse disease at less than 100 days post stem cell transplant, are at higher risk of treatment failure, and patients with higher disease burden at the time of their CAR T-cell infusion are also at higher risk of treatment failure. Next slide, please. So some of the other considerations for patients who are candidates for CAR T-cell treatment are patients who might otherwise be candidates for stem cell transplant, but can't handle some of the toxicities related to myeloablative conditioning. And so for those patients, receiving CAR T-cell therapy is an ideal scenario to sort of mitigate some of the treatment-related toxicities that they may receive. So some of the patients include patients with Down syndrome. So patients with Down syndrome have higher toxicities associated with myeloablative conditioning, and it's not recommended that they move forward with stem cell transplant. Patients who have evidence of significant organ dysfunction. So, for example, patients who have had a history of veno-occlusive disease with their prior transplant are at high risk of treatment-related morbidity. Patients who have contraindications to receiving radiation, and patients who have CNS disease, because we do know that from prior clinical trials that CAR T cells do have penetration to the CNS. Next slide, please. So in the late relapse setting, CAR T-cell therapy may be able to delay the relapse until the patient is older and can potentially tolerate more radiation exposure. As we've shifted towards exploring alternative donor transplants due to shortages in the donor pool, especially with sibling donors, there are patients who do not have any suitable donors available or don't have any suitable matches within the registry. And for those patients, CAR T-cell therapy may be a viable option, either as a standalone therapy or as a bridge. Next slide, please. So as I alluded to in the previous slide, there in prior clinical trials, the investigators have found that CAR T cells are able to cross the blood-brain barrier and clear patients who have CNS disease. Patients who have isolated CNS disease had similar relapse-free survival and overall survival compared with patients who had isolated marrow disease. And for those patients who had significant CNS disease burden, we found through the efforts in the clinical trials that they can be safely treated with CAR T cell therapy with the appropriate supportive care interventions implemented. Next slide, please. So one of the things that is now emerging, especially in the post-blinatumomab era, is the interaction or the interplay between patients who have received blinatumomab and those who received this therapy who are indicated for CAR T cell treatment. And so there was this thought that prior blinatumomab exposure may exhaust CD19 exposure, but for patients who have failed blinatumomab, there are patients who potentially can respond to CAR T cell therapy as long as they maintain their CD19 expression. So that's not a contraindication to not receive CD19 directed CAR T cell therapy if a patient has received blinatumomab and they maintain their CD19 expression at relapse. Those patients are still candidates to receive CAR T cell therapy. Next slide, please. So as I conclude, I'd be remiss without discussing access to CAR T cell therapy, because we've talked about some of these new and exciting immune modulating therapies, but those therapies don't have much utility unless the patients who need it can access it. And because of the infrastructure related to cancer care globally, we do know and understand that the majority of patients do not have access to CAR T cell therapy. And a lot of that is related to the logistics and technical aspects of administering and delivering CAR T cell therapy. You have to have facilities that can potentially provide apheresis collection, be able to ship to manufacturing, and be able to provide care for patients receiving cellular therapies. And we know that the vast majority of cancer cases occur in low and middle income countries, and that the vast majority of cancer-related deaths occur in those countries. Next slide, please. As I alluded to in the beginning, CAR T cell therapy is significantly more expensive. So there's also the issue of cost as well, and the burden of that cost on both private and public insurers. There's still some ambiguity, especially in the United States, regarding the pricing. And so the approval process is understandably very, very cumbersome as a result of that. And it seems unfair that the decision to approve these therapies for the patients who need them are left to insurers. But nevertheless, until we improve how these therapies can be accessible, this will still continue to be an obstacle that we need to overcome. Next slide, please. So some of the future directions related to CAR T cell therapy include investigating the role of CAR T cell therapy in the frontline treatment setting. I'll be curious to see how this looks in the post-blinatumomab era. The standard of care is still to administer blinatumomab upfront first for patients, and then still use CAR T cell therapy as a subsequent or second line therapy. But there are ongoing trials, especially sponsored by the Children's Oncology Group Consortium, that are looking into this. And then looking at the role of CAR T cell therapy in patients who've received stem cell transplant. And with all the different immunotherapies that are available to patients, understanding the interplay between each and when you would do both, which is very individualized and customized to the patient, their disease status, their prior stem cell transplant experience. So there's a lot of excitement for these therapies, but it's tempered by the understanding that there's more information that we need to learn. So with that, I thank you very much for your time and look forward to any questions that you have at the end. Thank you very much.
Thank you very much, Dr. George. Excellent presentation. Thank you very much for sharing with us. Now we are going to the next presentation. I'd like to invite Dr. Askar Jain. He will be talking about emerging applications of CAR T-cell in pediatric oncology. Dr. Jain is a pediatric hematology oncologist and director of the Inherited Bleeding Disorders and Hemoglobinopathy program at Loma Linda University's Children's Hospital, California. He currently serves on the International Pediatric Association Working Group for Sickle Cell Disease and is an American Society of Hematology ambassador. So please, it's over to you, Dr. Jain.
Thank you, Dr. Furman. I hope I am clearly audible to everybody.
Yes, you are.
Terrific, thanks. Just waiting for the slides to be uploaded, and just want to preface this wonderful series of conversations today about applications of novel therapies in pediatric oncology. As this talk is meant specifically for fellow pediatricians around the globe, and additionally subspecialists in pediatric oncology, I have repurposed my talk that I usually give to my fellows and colleagues to emphasize specific points that are relevant, in my view, for pediatricians and clinicians who do take care and identify and serve as our eyes and ears on the ground, whether it's in an ambulatory setting, emergency room setting, or a hospitalist setting taking care of pediatric patients. This is where I work. The focus specifically will be in discussing novel therapeutic options that are now available for addressing some unmet needs that still avail and face us on a daily basis when addressing challenges for pediatric malignancies. Learning from the stories of liquid malignancies in pediatrics, as was alluded very nicely by the two previous speakers, I will try to now highlight some of the emerging therapies that we would expect to come from bench to clinic in the next 5 to 10 years that are showing great promise and absolutely are going to revolutionize how we treat children with cancer beyond liquid malignancies as well. Next slide, please. Why this topic should matter to the pediatrician? Well, one can argue that this is highly specialized and a niche conversation, but where I commonly see barriers to access to care or barriers to knowledge gap analysis, I think one of the challenges that continues to happen in patients in resource-limited settings is delayed identification of leukemia, solid tumors, and certainly after successful remission, identifying patients that have gotten into relapses early. Getting patients to clinic for these novel therapeutics that carry a heavy cost burden is absolutely critical with respect to survival outcomes and event-free survival rates. Chimeric antigen receptor T therapy or CAR T therapy is one of the most important examples that have demonstrated that precision immunotherapy translates into durable remissions from multitude of malignancies that we can pinpoint an immunotherapeutic target for. And we are now moving beyond what I like to call CAR T 1.0 with novel antigens and novel targets in order to get better outcomes and strive to learn from platforms that have already been mastered with the respect of utilization of CAR T and repurposing it for other malignancies. Next slide, please. Just as a brief overview, I'm not going to spend a whole lot of time on explaining, as it was nicely described by the previous two speakers. This is a pictorial description of how CAR T cells or CAR T therapy is delivered in the clinic in our specialized cancer centers. The idea of demonstrating or simplifying this process, which by no means is as simple as it appears, is to understand that there are multiple steps that are involved in getting a patient from diagnosis and successfully administering the repurposed immunotherapeutic cells that have the potential to address cancer and leukemia cells into the body. The CAR construct, or chimeric antigen receptor construct, includes an extracellular antigen recognition domain that pretty much acts as a unique identifier and programs the T cells for the patients that are autologous in nature and address the leukemia cells in the setting of pre-ALL, for example, by enabling targeted cytotoxicity and minimizing damage to other alternate organ systems. So we're moving away from carpet bombing to precision medicine. And this is the slide that demonstrates that this is a complex, multi-step process. And we work with the primary care pediatrician hand in hand every step of the way to provide care for these patients, many times that are living in remote settings, by utilizing a hub and spoke model, especially for patients that are not having easy access to a specialized therapy center. Next slide, please. As was alluded very nicely by the previous two speakers, Tisocell, specifically the CAR T that is approved for pre-ALL, in and of itself speaks to the success story and proof of concept of why CAR T cell therapy should be the area that continues to evolve and require investment in, as this therapy has opened doors for us to be able to program novel immune targets for other malignancies that I'll be showing in the next few slides. So next slide, please. The idea of moving on beyond an immunotherapeutic target such as CD19 that is pretty specific to PB specifically is to understand and address some of the major technical challenges that CAR T therapy, the first generation CARs, are acting as or providing therapeutic challenges. The major mechanism of having failures in CAR T cell response is antigen escape, particularly loss or downregulation of CD19 on leukemic blasts. This technical complication sometimes gets in the way of reaching the desired immunotherapeutic response in patients. And this continues to pose as a problem in patients who do successfully have access to these novel therapies, but yet still don't have the desired outcome. The understanding or the idea behind demonstrating such critical niche clinical challenge is that there is hope as we are moving beyond CAR T 1.0 by addressing other immune therapeutic targets and developing CAR T therapies that will be less driven by can it work to how can we prevent failure in order to ensure long-term durable immune response and elongating the life of the patient by keeping them in long-term remission. Next slide, please. So what is CAR T or CAR T 2.0? Is dual targeting using multiple immunotherapeutic targets to potentially amplify the effect of the immune T cells in order to weaponize them appropriately in identifying, hunting down, and creating an immune memory to destroy leukemia cells and leading to a durable long-term response. This idea of achieving remission durability and reducing antigen escape would allow patients to have a smoother course in terms of their long-term event-free survival, and certainly allow patients to live much longer free of leukemia. The dual target targeting is conceptually attractive because CD22 has already been validated as a salvage target in pre-B ALL. So adding on to other immunotherapeutic targets that are expressed on a pre-B or leukemia clone is absolutely the next step to go in doing more precision immune oncology. Next slide, please. As was addressed previously, the question of using CAR T therapy or a novel immunotherapeutic therapy as a solo option, or to use CAR T as a bridge in order to put a leukemia patient that has relapsed into remission and creating a bridge to successfully then take them to stem cell transplant is a very hot topic that is being debated in national and international corridors. It is a moving target, but suffice it to say, addressing cellular therapeutic targets and immunotherapy usually go hand in hand. And the clinical message for the pediatrician by putting forth this point is that future pediatric algorithms will likely integrate CAR T as part of treatment pathways rather than as an isolated rescue maneuver for patients where all other options have been exhausted. This is a message for hope and improved survivorship for patients. And the message to the community pediatrician is that who has had relapse, whether it's isolated marrow relapse or extramedullary relapse, there are improved therapies that are coming that are addressing targets and helping patients to bridge to curative options such as stem cell transplantation. Next slide, please. Next slide, please. Moving on from just pre-B acute lymphoblastic leukemia, other therapeutic targets and other disease conditions that are now being addressed by utilizing the CAR T immunotherapeutic pathway are non-Hodgkin's lymphoma. Studies that are being currently done in pediatric and adolescent non-Hodgkin's lymphoma, especially B-cell non-Hodgkin's lymphoma, are showing terrific responses in patients that have multifocal disease or relapsed after conventional chemotherapy. The translational borrowing from adult lymphoma into pediatric disease with careful attention to biology and toxicity differences are the things that we are now honing in clinic through clinical trials and individualizing these therapies for the pediatric and adolescent population. And this is an important area of expansion because relapsed non-Hodgkin's lymphoma has very poor outcomes with conventional salvage chemotherapy. So having a B non-Hodgkin's lymphoma, especially mediastinal disease or metastatic non-Hodgkin's lymphoma who has failed conventional chemotherapy, especially patients that have early relapse, are patients that commonly do poorly. So this has behooved us to reinvest into therapies and reprogram CAR T pathways in addressing this very significant unmet need of non-Hodgkin's lymphoma in the pediatric and adolescent population. Next slide, please. What has eluded pediatric oncologists for decades is how to address solid tumors. We've had conventional chemotherapy, maybe a cohort of 4 or 5 chemotherapeutic agents that we have used in various combinations to address solid tumors, whether it's Ewing sarcoma, papillomyosarcoma, osteosarcoma, and additional other round blue cell tumors that have classically been very refractory in the metastatic setting. These solid tumors are the most ambitious emerging applications of CAR T in pediatric oncology. Having witnessed the recent talks and presentations at the American Society of Pediatric Hematology Oncology and the European Hematology Association, it is pretty evident that the therapies that are already in clinical trials are showing remarkable, tremendous progress. As an example, osteosarcoma, especially metastatic osteosarcoma, that has disproportionately affected outcomes for patients even after receiving successful chemotherapy, whether it's high-dose methotrexate-based conditioning or therapy, or ifosfamide, etoposide-based condition therapies or backbone in metastatic cases, do terribly if the disease continues to take a turn for the worse. Seeing the data that was presented by targeting novel CAR T therapies such as oncostatin M or OSM CAR Ts, and the data that was also presented for folic acid receptors alpha or FOLR1 CAR T with limited phase 1 and phase 2 clinical participants shows clinical tremendous progress in previously diseases that were not found to lead to a lot of event-free survival with confidence by pediatric oncologists. Additionally, while we utilize these targets like folic acid and oncostatin M for osteosarcoma and inject the CAR T cells or reprogram the immune therapies to address these specific osteosarcoma markers, there is an additional development of integration in another remarkable breakthrough in human medicine, which is gene therapy. Identifying tumors that we know and are confident through next genome sequencing, specific tumors that demonstrate genetic mutation that are highly correlatable and are expressed in tumor cells all around the body, identifying gene therapeutic targets and reprogramming T cells with even more precision, and integrating CAR T reprogramming with immune precision by using molecular scissors in making the CAR T even more potent are the therapies that are not the things of the future, but things that are actually in clinical trials showing tremendous response. Why this is critical, one is the additional practical aspect of emerging costs associated with these culmination of two therapeutic modalities, but more importantly, knowing that we have these therapies that hopefully will be put in clinic by regulatory bodies and having approvals, there will be patients across North America and or Europe, which will then bleed over, if you may, in patients that really absolutely need these therapies in low resource income, middle income countries, and allowing CAR T, novel CAR T therapeutic targets with osteosarcoma, neuroblastoma, and other solid malignancies around blue cell tumors that were previously considered to have very poor outcomes once they become metastatic or relapse. Next slide, please. The last couple of slides demonstrate certain new CAR T therapies, especially GD2 CARs that are now reprogramming neuroblastoma, and they identify these novel therapeutic targets in treating these patients with utmost precision and providing cures or a shot at cure for previously incurable cancers. Next slide, please. Additionally, brain tumors have always eluded neuro-oncologists, especially diffuse intrinsic pontine gliomas or midline gliomas that have classically been considered a death sentence. Novel CAR T therapies that are reprogrammed in identifying novel tumor markers within the DIPG cell lines are in clinical trials showing tremendous response in prolonging life of patients beyond 6, 8, 9, and 12 months. Next slide, please. Next slide, please. This is just a summary slide of toxicities. I think to the pediatrician to understand that this process is complex and is having toxicities such as ICANS, cytological responses, some things that were previously discussed in great depth. I'm not going to spend a lot of time, but I think the parting message would be that for the pediatrician who's seeing these patients in an ambulatory setting or an acute emergency room setting, it is important to understand and identify these toxicities very early on so that patients can have access to timely management, such as immune suppression, and getting these patients to have enough time for the therapies to act successfully. I'll end here with this conversation. Thank you for your time and attention, and I'll be open to taking any questions, if any. Thank you very much.
Thank you very much, Dr. Jane. Very wonderful presentation, very good for everybody to see all the progress that has been done in the area. Now, I think we will move on to the question and answer. if you can put in the chat your questions, we can say here.
Two questions in the Q&A.
Uh-huh.
There are 2 questions already in the Q&A.
There are already, I'm not seeing here.
Okay, I'll just read one of them. In view of the profoundly exorbitant prices of new modalities of cancer therapy, the persistent, apparently unavoidable toxicities of treatment, is it not time that more effort be spent on preventive oncology? So that's for the speakers. Dr. Anita, you want to take off on that one?
Yeah, sure. So, yeah, it is a nice thought that people can cancel altogether. Then we can actually reduce the cost of all this and reduce the toxicity as well. But the sad fact is, unlike in adult oncology, so preventive oncology is like we would have heard about preventing tobacco exposure or preventing exposure to HPV infections. So all of that prevents cancer. So we know now that there is HPV vaccination that prevents, reduces at least the prevalence of CS cervix and many other malignancies, gynecological malignancies, etc. So now in pediatric cancer, sadly, that's not the case. Pediatric cancers cannot be prevented to a large extent. Probably HPV is the only vaccination which is available. And that too, it will prevent cancer in adulthood. It is not going to prevent cancer in childhood. So for all the cancers that we discussed today, leukemia, lymphomas, solid tumors like neuroblastoma, Wilms tumor, retinoblastoma, there's hardly any preventive option available. So because of which, in pediatric cancers, what we rely on is early diagnosis. So yes, if we diagnose these children early, then many of them can be treated with lesser intensive treatment, the earlier stage disease, especially the lymphomas and solid tumors. If they were picking up early, then lesser treatment. We may not have to go through this advanced treatment, and we have lesser cost of treatment, lesser toxicity, definitely. But that's just early diagnosis. And sadly, early diagnosis is also not possible in many conditions. For example, leukemia, when the onset of symptoms come in, that's when you have when you pick them up. Preventive oncology is sadly not possible for majority of the cancers that we treat in children. Thank you.
If I may, Dr. Kure, I may have a comment as well.
Okay, great.
No, absolutely. I agree with Dr. Radhakrishnan. Pediatric oncology is especially obtuse just because of the fact that there is not enough environmental exposure for us to have any preventable strategies to put in. But just from personal experience, I think there are certain things that are maybe pertinent for the pediatrician. As we all know, for pediatricians who've been first, second, third generation pediatric specialists that have trust with families. So certain cancer predisposition syndromes, whether it's Beckman or Lee-Fraumeni, or syndromes that we, as a physician or clinician, can identify by taking a good history and identifying, for example, having a family member with multiple malignancies or history of multiple malignancies in an entire family, I think should be a wake-up call, and certainly a reason for early referral, even if it is for tumor surveillance. Another example is Beckman syndrome with Wilms tumor that commonly presents to patients much later with rupture, which sometimes can become very difficult to manage. So I think having a high index of suspicion, especially with the history of multiple family members having malignancies, should identify and I think inform the pediatrician to maybe think in those lines and surveil those patients more intensely and maybe with a little bit more rigor. That's the end of my comment.
Thank you very much. Dr. Sima, have you seen the Q&A?
Let me see here.
There's another question there.
Yeah, I don't see the Q&A.
Okay, what are the common mechanisms established or suggested for failure of CAR-T therapy? In bracket, non-responses or relapses. So that's for Dr. Anil Judge.
Thank you for your question. I think there's three main categories that I think of regarding suboptimal response with CAR T cell therapy. So the first category deals with the manufacturing of the CAR T cells, and whether in vivo, if there is an issue with the CAR T cells not expanding or not having sustainability after they're manufactured, or just not having very functional T cells. So for example, in a situation with a patient or patients who have been exposed to multiple effects from cytotoxic chemotherapy, that may lead a patient to not having optimal functioning T cells that are collected. Because again, these are a patient's own autologous T cells that are collected and manufactured and made into the CAR T cell therapy. So that's the first category, an issue with the cell expansion related to the manufacturing of the cell. Then, as Dr. Jain mentioned in his last talk, he had alluded to tumor antigen escape. So the leukemia cells in and of themselves can have their own mutations and downregulate some of the factors that affect how the T cell, the CAR T cell, and how the leukemia cell interact and induce killing. So there could be mutations that happen at the tumor level that affect that. And then the last category is related to just T cell dysfunction or T cell exhaustion. So at some point, and this is what comes into play with patients who relapse subsequently after CAR T cell therapy, at some point the T cells get exhausted, so to speak, and can have their function affected. Also, there's the inhibitory signaling that we can see with checkpoint inhibitors, and the way I think of checkpoint inhibitors is I think of it in terms of like a light switch. There's something that happens within the interaction between the CAR T cell and the leukemia cell, where there could be like an upregulation where that switch is turned off, and it allows the leukemia cell to escape the activity. That's sort of the working theory with how leukemia cells are able to evade some of the effects from the immune cells. It is through the upregulation of these immune checkpoints, and that's the premise or the basis behind immune checkpoint inhibitors. So I know that's sort of a long-winded way of answering the question, but I would say the main categories are related to expansion, antigen escape, and then T cell dysfunction.
Thank you very much, Dr. George. I think
I have one question.
Oh, okay. Please go ahead.
Yes. Do you foresee in the near future that some cases with tumors in children will replace the CAR T cell, will replace the stem cell transplantation?
That's a very good question, and that I know is being studied as we speak. The Children's Oncology Group has an ongoing trial right now that's looking into that. Right now, the short answer is that everything is on a case-by-case basis. While we're talking about all these novel therapies, the fact of the matter remains that these therapies are very individualized to the patient. It's looking at the patient's age, their disease, their other associated comorbidities. But as far as CAR T cell therapy replacing transplant, it's going to be on a case-by-case basis until you have more data that says CAR T cell therapy is better than stem cell transplant. I'd say right now that we don't have any data to support that. And if you talk to some subspecialists, they would say that for a patient who achieves remission either through CAR T cell therapy or through another immune modulating therapy, the fact of the matter remains that the patient doesn't have any other comorbidities and can tolerate it. The recommendation would still be to move forward with stem cell transfer for the best chance of cure.
Okay. And the other question I have is, because we are waiting for the CAR T cell for solid tumors, and we see that it's far lagging behind. And then what is the realistic opportunity that we'll be able to be using it for solid tumors?
Is there anybody specific that this question is for, Dr. Seema?
Yes, yes, for you. It's for you.
No, certainly. As I mentioned, both at EHA and ASFO this year, seeing the data that was presented, I mean, metastatic osteosarcoma, as you know, once those patients come in with metastatic, the first thing that always crosses my mind is getting a palliative care consult and, try to have that discussion, because we know these patients classically don't do very well. Seeing the data, especially the CAR T data using the folic acid receptors, the FOLCAR, the phase 1, phase 2 data that was presented at ASFO with 3 patients, data that was shown with event-free survival upwards of 75% is absolutely the revolution we've been waiting for solid tumors. And I think similar data was presented for metastatic neuroblastoma and diffuse DIPG. Now, these are 3 tumors, as we all know, that tend to have the lowest event-free survival and response to therapy. To your question specifically about how long will it be before they actually become approved therapy, as we saw the progression of CAR T and gene therapy for classic hematology conditions, because the disease burden and load is immense, I'm very hopeful that before the end of this decade, these therapies will be FDA approved or EHA approved and will then be available to then be repurposed as CAR T story evolved over the last 5 years, whether it was the India example, Middle East example. So I think the hopeful, optimistic answer is before the end of this decade, we'll have these therapies available for wider use. Word of caution, these are therapies with immune therapeutic targets that are being tested out for the first time. So long-term toxicity, long-term surveillance absolutely needs to be the critical endpoint as infrastructure and SOPs are being made, even for solid tumors, to address some off-target effects that we continuously need to surveil. So hopefully that answers the question.
Thank you. Yes, you answered. Thank you very much. The question that I'd like to ask again, what do you think about how the challenges in low and middle income countries for us to have access to all this so expensive treatment?
I'll just go first. I was just in Brazil 2 weeks ago for the Latin America hematology meeting. And I think, as you probably are very well aware and acquainted, access to therapies, distribution, and cost continue and remain to be the major unmet challenges. As an example, again, we are going off topic a little bit. Extended half-life factor products for hemophilia B in Brazil are still not available for patients. Whereas for hemophilia A, we are already talking about the launch of TFPI antagonists and extremely advanced hemophilia A therapies. So just goes to say that I think advocacy and leadership decisions absolutely play a critical role in identifying really where the need is to bring those therapies and avoid red tape. I'm currently in India and seeing a ton of oncology patients and seeing these familial cancer predisposition syndromes play out in a massive amount here in the largest, most populous country, again, brings me to the point and the question that I think cancer surveillance, having a higher index of suspicion for patients, in identifying them early remains to be the key, and low-hanging fruit and actionable targets as therapies come up to speed.
Thank you. Yes. Thank you very much.
Thank you very much. Thank you very much, Seema. I think we've really overshot time, but Hassan's hand has been up. That would be the last question. Hassan, can you quickly do your question so we can close the session? Thank you. You can unmute and ask your question.
Who is?
Hassan Baptiste. Is that a hand or?
There's a question there already. Do you want to read it out?
No, we've
it's the answered section. No, it's in the answered section because I thought we'll answer it live. So if you check the Q&A answered section, the question comes up there. So it's not a question, rather it's a comment. I can read it out. So it says in India, a CAR T has been developed in Governmental University Center with much less cost. By the way, it was accessed and approved from US. This opens our hope as low-income countries to get some equity for effective cancer therapy and immunotherapy and targeted therapy. So it's more of a comment than a question. Yes, so it was developed in India at a fraction of a cost. So it is available currently to patients at who are not in trial. For just purchasing it, it's available at a cost of around $40,000 US, and as in 40 lakh Indian rupees. So I think it should be around $40,000 US, I am presuming. And now it is available in pediatric patients. It is currently trials are ongoing as well. So it is available at a small fraction of what is the cost in high income countries. And we hope that it actually improves access to care for these patients. And with more companies coming in, again, there will be competitive pricing and more equity in healthcare delivery. Thank you.
Thank you very much, Nita, for that very useful information. And at this point, we are about to bring the session to a close. We have had three outstanding presentations today, and I want to leave us with what I believe are the essential messages to carry forward. One, the landscape has fundamentally changed. Survival in pediatric cancers like ALL has transformed over decades, but we now know that further gains will not come from adding more chemotherapy. They will come from precision, using genomics, MRD, and treatment response to decide who needs more and who needs less. Secondly, targeted therapy and immunotherapy are no longer the future. They are the present. TKIs in Philadelphia chromosome positive ALL, NTRK inhibitors in fusion tumors, blinatumomab in MRD positive ALL. These agents are producing remissions and saving lives in children today. And crucially, they demand that we actively manage new toxicities like CRS and sinusoidal obstruction syndrome, or we will lose the gains that we have made. Third, CAR T-cell therapy represents a genuine breakthrough. Over 90% MRD negative responses with a single infusion. It's filling a gap that transplant alone cannot fill. And it is expanding into lymphoma, neuroblastoma, and even brain tumors. But it's not without limits. We have antigen escape, late failures, and then the hematopoietic stem cell transplantation, sequencing question all remain. Finally, and I cannot stress this enough, none of this matters if our children cannot access it. 65% of cancer deaths occur in low and middle-income countries. A therapy that's priced at $475,000 that requires infrastructure exceeding transplant centers is not yet a global solution. And I'm happy that Nita has given us some hope that in India, we can get these at a much lower cost. So that is definitely the work that's still ahead of us to ensure that children globally have access to the new breakthroughs that are coming. This brings us to the end of our session. I say a big thank you to the IPA President, Professor Joseph Haddad, for joining us. I thank the moderator, Dr. Seema, and the three speakers who did a great job. And most importantly, I thank all of you who made out time to attend this webinar. And finally, I want to hand over to Dr. Ashwara to talk about the feedback form. Thank you very much for coming.
Thank you, Dr. Kekin. So thank you all speakers and the participants who have joined us. Now here is the feedback form which you can scan to fill the feedback form so that you will receive the certificate. Thank you.
Thank you to the IPA team. Thank you, Dr. Kanem, Dr. Seema, Dr. Anil, Dr. Akshat. I think we can close the call. Thank you. I think it went well.
Thank you so much.
Bye-bye.
Thank you, IPA team. Great job. Bye,
Thank you.
everyone.
Bye.
Thank you all very much.
Thank you very much.